Hi, good afternoon. I'm Tony Fuente, and I am with you this afternoon to share a few ideas regarding the CPT system. And what I'm going to do is I'm going to give you a series of concepts based on PowerPoint, and I'm going to shift from the pretty face that you see in front of you to the screen, which will have all of my slides. So with that, let me move on, and I look forward to spending this next hour with you. And I'll be happy to accept questions as I can. And at the end, I'll leave some time to address them as best as I can within the time constraints. So again, thank you for joining me, and I look forward to sharing this next hour with you. All right, so we are now going over to there we go. We are having problems loading, so there we go. Thanks. Well, welcome to the audit, with the webinar number 1. This is the basics of CPT. For those of you who heard me before, I always begin with a disclaimer that I provide the best information possible. By no means am I certain that this is completely correct, but it's the best to my knowledge. If you see or hear anything that you'd like clarified or you have additional information, please share with me. There are lots of people and lots of organizations have been very involved in helping us out. North Carolina Psychological Association got me involved at the very beginning. Other groups, including the American Psych Association, National Academy of Neuropsychology, as well as the Division of Clinical Neuropsychology, has been very supportive. I've worked all along in a close collaboration with the practice directorate of the American Psychological Association, and most recently with a stint on the ethics committee. There are many people that have been very, very active. I'd like to take a moment to do a shout out to several individuals at APA: Randy Phelps, Norm Anderson, Catherine Nordahl, and AMA, Marie Minderman, Tracy Gordy, and our recent CPT chair, Peter Holman. There's a great deal of support that's come, but I have to be honest, that's been mostly in the way of indirect and not financial, but here's the information. And whatever support does come in goes to the university's graduate fund to be able to support grad students. I've been involved in this since 1988, first through the North Carolina Psychological Association and on through the CPT panel, which I happen to be on at the present time. Those are the different stepping stones to getting to this particular juncture of this very long and winding and complicated journey. So to get into the specifics, let's make sure that you realize that this is aspirational information as best as I can, but it should not basically go against the APA Code of Ethics, HIPAA, state, provincial license regulations, professional standards, and most importantly, the contractual agreements that we all signed or other people signed for us. And keep in mind that you ought to read each of these contracts because they provide the limits and the horizons for the kinds of things that we all aspire to do. The goal has been very simple since 1988, and that's parity with physicians, and to essentially extend the scope of practice to reflect the science and practice of psychology. The outcome has been similar reimbursement, general increase in the scope of practice, and inclusion in the healthcare system. Unanticipated, but not necessarily bad, is the transparency, accountability, uniformity, and potential impact on certain practice patterns, constant change, and a shift, as you'll see over the next few webinars, from fee for service to fee for performance. I will share with you that a lot of people give me a great deal of acknowledgement for changing practice patterns, and a lot of people also give me a great deal of grief for making life worse for them. This is something that I wish I could take full credit for, but I'm basically one of many individuals in changing or trying to change the healthcare system. So bear in mind that this is just one person in a large cog. Now, why is this information important? It's very simple. The Medicare sets the standards, and for what it's worth, Medicare is the owner of the current procedural terminology system. So as a consequence, it's critical to appreciate that what we have here is essentially a system which is set by the federal government, and it will be the foundation for the healthcare law, which will change drastically. And as you know from last Friday, will also has been upheld by the Supreme Court for the second time. So it's unlikely to go away, and it's by far the largest change probably since about 1965 with the introduction of the Medicare system. And without it, this is the largest change in the history of healthcare in our lifetime. And of course, on October 1, 2015, we are very fortunate to be jumping into an entirely new diagnostic system, which at this particular point, it looks extremely likely to move forward. So now let's jump into the actual part of the presentation that I want to share with you guys this afternoon. I'm going to be talking about coding, billing, and documentation. So with this in mind, I want to go into the Medicare system. Yes, thank you. And I'm going to, first of all, begin with something that's been evasive for us, and that is Medicare's definition of a physician. Some of this comes from a recent talk by APA practice organization staffers, including Doug Walter, who's got his finger on the pulse. And first of all, I think it's fascinating to know that in the Social Security Practice Act, essentially, which actually was enacted in 1981, physician defines individuals with a doctorate degree in medicine, osteopathic medicine, dental medicine, optometry, chiropractor, but unfortunately it fails to include psychology. The question, of course, why? The term qualified psychologist or psychological services means such services and supplied furnished as an instant to his service furnished by a clinical psychologist. Essentially, it's important to appreciate that the phrase clinical psychologist is not in caps. So it includes such individuals as counseling psychologists, health psychologists, neuropsychologists. And if the state law covers that service by a physician, then theoretically that is a qualified psychological service. This is, again, according to the Social Security Act, and for that matter, is found in the recent writings in the CMS website, Center for Medicare and Medicaid Services of 2015. Now, let's try to operationalize what a psychologist is, which is at the very fundamental core. It's a clinical psychologist. It is not defined as a physician. Therefore, in many ways, since it's not defined as a physician, as you saw from a previous slide, we are by definition a technician. There are two kinds of people that work in the healthcare system according to the US government, a professional and a technician. A professional does the cognitive work, whereas a technician does the technical work. They don't think, they just do or follow a series of directions that have been provided by the professional. So essentially, we are finding ourselves in a situation where we have individuals who have doctorate degrees but are not considered to be professionals. This turns out to be a major problem for psychology, as I'll share with you throughout our presentation this afternoon. Now, the specific definition, as you see, is found in Chapter 12 on the processing manual. And I want to emphasize a couple of things. First of all, this is the first time that you see clearly that clinical psychology is defined, psychologist is defined as a provider of diagnostic and therapeutic services. However, what's also interesting, and maybe even more important in some ways, that they also include psychometrists, which of course it's a bit problematic because we have a very different interpretation of such. So in all practical purposes, to make life as simple as possible, let me explain to you what a psychologist is according to CMS or the federal government. You have to have a license or certification, number one. Two, you have to have a provider number. You have to be a provider according to Medicare. You have to have some kind of reference source. You have to be found in the APA directory, a state association, national register, etc. They're fairly open in that regard. You have to have a doctorate degree, either a PhD or a PsyD, and your school must be accredited. Okay, so let's explain to you why understanding the Medicare system and by implication the CPT is critical. I think most important is the fact that the benchmark for all kinds of healthcare services is essentially Medicare. It is the Workers' Compensation Foundation. It indirectly applies to forensic applications, and in essence, it's the standard, the benchmark from which everyone goes. Some companies are more likely to be Medicare Plus. For example, Blue Cross Blue Shield sometimes is, and sometimes companies are Medicare minus. For example, some of the carve-outs that have historically existed, like Wellspring and so forth, so on. All right, so keep in mind that at this particular point, Medicare represents 50% of all healthcare in the U.S. And the way it's moving along, it most likely will be by default the healthcare insurance of the United States. One model, which I've actually talked about on many occasions, is that Medicare will come from above, that is, older individuals, and little by little, Medicaid, which resembles Medicare, will come from below. And as time goes on, the two will merge, and then you'll end up having a unified healthcare insurance system that will apply to all individuals. Excuse me. Now, this is a very, very, very critical slide, and I want to emphasize this repeatedly today and throughout the rest of our 5 webinars. First of all, Medicare is national policy that's vetted out, and I'll explain how that is. However, it is important to appreciate that it's all about local coverage determination. An LCD sets a local or regional policy, or by indirectly, it actually sets up the foundation for a contractual relationship. It overrides national policy, but it also means that theoretically the national policy is vetted scientifically and diplomatically. One could argue that you could always push forward to have that accepted by your local carrier. So now we're going to go into, in essence, the core of today's presentation. For the next 40 or so minutes, I will share with you some of the more important or salient things regarding the current procedural terminology system. And as I do that, let me share with you that this is copyrighted by the American Medical Association, although, as I've inferred, and I want to emphasize, that it is actually owned by the Centers for Medicare and Medicaid Services. So what's a CPT code? It's a coding system developed by AMA in conjunction with CMS to describe professional healthcare services. Each code has a 5-digit number, a description, and a reimbursable value. And it's critical to appreciate this kind of service must occur in multiple locations throughout the U.S. And for that matter, that it should be documented by peer-reviewed scientific professional literature. Also, I'll discuss this a little bit, and that is that the physicians or qualified health professional perform those services. CPT system is moving away from the word physician and moving towards qualified health professional. I do not believe that there's any code that applies to psychologists and for that matter, well, certainly psychologists, possibly social workers, and where qualified health professional does not include physicians. This system is basically developed in 1966, was developed in 1966 by surgeons for billing purposes. At the present time, there are about 8,500 discrete codes. and the CPT system or panel, if you will, meets 3 times a year to add and in some cases delete these services. As I shared with you, AMA is under license by CMS, although CMS now provides very, very active input. And in fact, it's my personal opinion that if CMS is not supportive, that a code proposal may not see the light of day. Now, what is a CPT provider? As I mentioned to you before, a physician or qualified health professional is an individual who, by education, training, licensure, etc., and privileging, can perform and does perform a service. So, in essence, we are qualified health professional. Again, and emphasize, we have moved away from using exclusively the word physician to using the phrase qualified health professional. Clinical staff is a person who is under the supervision of a physician or qualified health professional. Historically, psychologists have not had the opportunity to bill incident to services. In fact, for all practical purposes, we are moving away from incident to services, but that essentially means that we can use non-doctor level providers who are not licensed to provide services under direct supervision of others. Okay, so what's the rationale? The outgrowth, as I mentioned, is the development of a Medicare system, which we sadly were not included, probably because of our own fault, in 1964. And the whole purpose is to provide a uniform system for all healthcare procedures, is developed, approved, and used by all healthcare professionals and third-party carriers in the U.S. and increasingly in other places. Korea, China, and others are starting to move towards this. The anatomy of a CPT code is essentially 5 digits. There's an inclusion criteria that allows you to use an exclusion criteria. The description, which is usually no more than 2-3 lines, is essentially the foundation for eventual auditing of these services. Now, how does CPT come about? The composition is as follows. The American Medical Association, quote, Council of Representatives, what they call the House of Delegates, is made up of 122 medical specialties. Each of those specialties can send a representative, which usually includes a team, often attorneys, staff members, who support the individuals representing the AMA subspecialty. For example, psychiatry has 2. And there's a Healthcare Professionals Advisory Committee that was started in 1992/1993. There were originally about 12 individuals that represented, or societies that were represented: optometry, chiropractic, podiatry, psychology. And subsequently, we've added several. I put a question mark because we're probably going to increase that number. Now, these individuals have 2 representatives on the, they all, by the way, they all have theoretically the same input as the 122 medical specialties. We're all sit around the large table to be able to provide our own comments. But when it's all said and done, those 137 or 8 individuals, or I should say more specifically specialties, healthcare specialties, all provide input to try and get a piece of the healthcare pie, which, as you know, is approximately 16 or 17% of the gross domestic product. That pie is sliced up essentially into 8,500 pieces, and the pieces belong directly, indirectly to those 137 health specialties. Those individuals present the ideas to 17 voting members. 11 are appointed by the American Medical Association Board of Trustees. There's also a representative from Blue Cross Blue Shield, the American Hospital Association, Health Insurance Association of America, and CMS. So essentially, there are 11 individuals who are practitioners, and 4 individuals are from industry. And then there's 2 others that are voted on by the Healthcare Professionals Advisory Committee, again, that was formed approximately 1992. I was on that committee since the beginning and served that role as as a representative to the American Psychological Association from approximately 1992 to about 2007, 8, 15 years after the fact, where actually I became a rotating member of the CPT panel. And 3 years ago, I was voted on as a permanent seat, which means I have another round, and that round continues through next year. So essentially, we would have had 8 years on the voting panel of the editorial panel. For what it's worth, in historical terms, there's been 3 other individuals before me that had been in that particular position. It's the first time a psychologist has been on the panel, and very, very lucky in many ways. And I think they're equally as surprised as I feel lucky. This is a very basic idea of how the concept of CPT works. First of all, the earlier you get into the system, the more you get reimbursed. Surgeons came in, physicians, then doctor level allied health like myself, and more recently non-doctorate level allied health. The rule of thumb, the earlier, the more reimbursement. Now, what is the value? How do you get a value? There's several things. First is what we have is a cognitive work, which is by far the most important thing. This is what you do to think. Only physicians do cognitive work. So for many years, we were living only on expense, which has to do with the cost of doing service. Malpractice is a very small amount, maybe 1 or 2%. And in addition to that, there's a geographic location factor that if you work in a rural section of the U.S., you get paid slightly less than if you work in an urban setting. And then, of course, the conversion factor, which everything is multiplied by, that's set by Congress every year. There are 3 categories of CPT. Standard is number 1. 2 is performance measurement, and 3 is emerging technology. I'll spend most of my time this afternoon discussing category 1, but I'll say a few words about category 2, largely because that is essentially the beginning of our future, and it's being fleshed out as we speak by PQRS, a Physician Quality Reporting System. And of course, the emerging technology, which essentially means if we don't have a lot of research at this particular point, but a lot of practitioners are involved, this could be the future of healthcare and the future category 1 code. The CPT code book has many different aspects to it. I'll share with you what they are right here. I do point out modifiers. It just turns out to be very important for certain unusual circumstances, such as testing. All right, so let's go into very, very simple definitions. First of all, CPT is current procedure terminology. It's the service code. This is not a diagnostic code like ICD or DSM. A QHP is essentially anybody today that is no more, no less than independently licensed to provide the service at the highest level possible in the state or province that they happen to reside in. Typically, and by definition, a QHP is also someone who has a contractual relationship with the insurance company. Anybody else, we call a technician. Let me also say a few more words about some other terms. What's a unit and what's face-to-face? A unit is anything that uses the foundation to multiply the amount of work provided by the professional, or in some cases by the technician. And face-to-face means in front of the patient. Now, I wish I could tell you this is really pretty easy, but it's not. It takes anywhere from 2 years to 12 years to get a code approved. It's about 70% or so of all the codes that are presented tend to be accepted. The question is, how long does it take to get accepted? In this particular slide, it gives you an example of one code set, and that's the testing code. And you can see in this graph, so to speak, that the first time that we introduced this was 1994. And I have to tell you, folks, we're still working on the testing codes, and I suspect it will be an ongoing process. So the only thing that I can assure you that comes from this particular slide is a lot of frequent flyer miles. All right, so what's a Category 1 code? This is what we live in. That's a code that you want because they're clinically recognized, scientific validated, and national in scope. So we use for levels of evidence for that. And as you can see, some levels are much more important. For example, meta-analysis and randomized trials is really the way to go. Category 2 codes are, if you will, probably not so frequently used, but it could be the beginning of where we're headed. Essentially, this is performance code. All Category 1 are basically fee-for-service codes. These are basically fee for performance or quality. And essentially, they're basically developed by small groups, and they're more specialty driven than anything else. I do think that we have to be very careful as electronic health records become the norm, that this may be how we might begin to bill. Category 3, essentially, these are temporary codes. They're not expected to last forever. And for emerging technology services, they're really intended to avoid local coding by small carriers and become part of the CPT system. They may or may not produce reimbursement, and conversion can be requested by society by CPT. The rule of thumb is that a Category 3 code should last no more than about 10 years. We have just had a bunch of new Category 3 codes that came into existence, and those are the applied behavior analysis codes. Now, let's move into the second half hour of our presentation by focusing on very, very interesting and new ideas regarding CPT coding. And then I'm going to give you some basic information regarding other related issues that are critical to serve as a foundation for our understanding of this coding system. I'm going to be discussing with you for the next several minutes the concept of what I call a base code, an add-on code, and a shifting code. A base code is a foundation code which captures the overall concept of procedure. It is expandable, and the foundation code must be present for each reported activity. Imagine, for example, a heart surgery. The basic heart surgery could be the foundation code, and then from that comes, one bypass, two bypass, and so forth, so on. The same thing applies, for example, to psychotherapy. We'll discuss that later on. And in essence, you can have a base psychotherapy code, and you can add to that depending on the complexity of the code. An add-on code is what you add to the base code. You must start with the base code, and if you want to, or it appears appropriate, I should say, the add-on code is then follows. It could be more work intensive, as in the psychotherapy code, or it could be additional time. In the crisis code, you start with a foundation of a few minutes, and then it could go on up to, say, the entire day. The foundation code must always precede the add-on code. Now, when do you shift a code? Excuse me. You shift a code when there's a significant disruption of service, and a new service is then coded. The assumption is that the professional would not return anytime soon to the original code. Now, there are about 8,500 plus codes, of which about 70 of those apply to psychology. They're in several main sections. The section that we have begun, our history, is essentially psychiatry, mental health. And we are revising it as we speak, continuing to move on to newer places. We have the biofeedback section, not very big. The central nervous system assessment section, which is very big. The physical medicine or PMR section, which is really pretty much out of bounds to us. Health and behavior section, which is real critical. Team conference, emerging but not so much. Evaluation and management, which is essentially not applicable to most of us, although I'll say a few words next time that we have one of these webinars And as I mentioned, the applied behavior analysis are category 3 codes. But for our practical purposes, there are essentially 3 kinds of codes. The mental health codes that were started in the 1970s. We can't find the exact history, but we think it started in the 1970s. The neuropsychological codes, which I helped add in 1990s. The health and behavior codes in the 2000s, together with Randy Phelps, together with the Interdivisional Healthcare Caucus group, basically put that together, and we moved it forward. And then there's new codes that are coming along, including telehealth, which I believe will become an increasingly critical part of the delivery of healthcare services as we go on. I do want to say a few side words regarding what we call HCPT codes, which are rarely used by psychologists, but there is a possibility, and we should look into the idea of using this HCPT to add the cost of a particular service. For example, if forms cost a great deal of money, could we add that to the foundational code? Sometimes you see this in surgery, and it's something that we should consider using in psychology in the future. Now, let's talk about what is the appropriate code for CPT. First of all, you choose the code that describes the service. You do not choose the code that describes the income that you desire. You use the code that describes what is it that you're trying to achieve. And you match the interview with a testing code, intervention with a diagnosis. It is possible, maybe desirable in some cases, to mix codes. But these being equal, you should have parsimony, uniformity, and fluency. We'll emphasize this the next 4 webinars, where I try to emphasize the idea of a series of, if you will, silos that could be interactive in the long run. There are several codes that are there, of those 8,500 codes, but unfortunately, they're not being reimbursed at the present time. Telephone calls, team conferences, patient education, and prevention. Of these, the one most likely to change is prevention, and it's emphatic, critical to appreciate as time goes on that we're going to be moving from treating individuals who are ill to treating individuals who have diseases and individuals who are trying to avoid diseases. So prevention will be the new healthcare frontier for many of us, and I could actually see individuals, especially some of our young practitioners, that will eventually move into a world where they don't deal with diseases, they simply deal with wellness. Now, there are emerging problems. That is mixing psychiatric codes with non-psychiatric code, inappropriate use of or estimates of time, and the ABA codes, because right now there are 3 category 3 codes, and at this particular juncture is a major, major problem. Combining biofeedback and psychotherapy still is an issue, and for that matter, coding by income is something that needs to be avoided. It is the foundation for fraud, and essentially it is antithetical to APA ethics, state licensure, and basically good healthcare. All right, so let me move a little bit from the CPT foundation to talk about diagnosing. Let me start by explaining to you there are 2 simple diagnostic systems out there right now, and that's a DSM and ICD. And I think it's sometimes a misnomer, or maybe an unusual circumstances why psychologists prefer to only diagnose one thing. Physicians diagnose multiple things, and I think it may be of some value for us to begin to do so. Let's take a few minutes to describe to you the difference between billing diagnosis and clinical diagnosis. Billing diagnosis is what you go after. That is what you put on the form when you submit that to an insurance company. Clinical diagnosis is what you conclude. It may or may not be the same as the billing or the original working diagnosis, but the billing diagnosis is what you went after. So, for example, if you're a neuropsychologist and the question is if is there dementia, and at the end you discover that what you have is depression, you diagnose in the bill essentially dementia. The clinical diagnosis is what is the end of the report, and that will be, as I'll share with you in a moment, the medical necessity for eventually proceeding with more mental health work. Do not mix psychiatric and non-psychiatric DXs when requesting authorizations. Choose the primary DX for the original request, and choose all DXs for the report and possible interventions. Again, diagnose all the pathology that has been discovered in the evaluation. As you know, essentially the start date, it looks like it's not going to be October 21. It looks like it might be October 1st, but either way, it's moving down that path. I find it fascinating that the rest of the world has been involved with ICD-10, and for good measure, as soon as we jump into ICD-10, we have to get ready for ICD-11, which will come out 2 years later. All right, so let's shift our focus here to discuss the concept of medical necessity. We sometimes confuse scientific and clinical necessity. And LCD's local medical determination may not reflect the standard clinical practice, and for that matter, may not reflect scientific necessity. Necessity is simply defined as a formulary that outside the Medicare system is essentially proprietary. That is not accessible to those of us who are not part of the inner circle. That is, we don't work for example, CPT or, for that matter, Blue Cross Blue Shield. And essentially what we have here is a CPT by diagnosis. So, for example, neuropsych testing could go with dementia, just like psychotherapy should go with depression. But should you do neuropsych testing for depression? Well, one could argue that intractable depression might require neuropsych testing, but the formulary rarely provides that. Should you do cognitive rehabilitation for schizophrenia? Makes sense. There's some science that supports that, but most formularies do not allow that. So, essentially, important exclusions. Screening is not medical necessity. Scheduled evaluations on a timely basis does not mean medical necessity. And repeated evaluations without documented or valid specific purpose do not meet medical necessity. What does this mean? If you get audited, the money has to be returned. Now, what is medical and reasonable? Services which are reasonable and necessary for the diagnosis and treatment of illness or injury, or to improve the functioning of a malformed body member. A malformed body member could be the psyche, could be the brain, and so forth, so on. And a reevaluation should only occur when there's a change in diagnosis or symptom. In essence, if the individual gets worse, it becomes suicidal, if the anxiety gets to the point that the person begins having psychotic symptoms, then theoretically, that is when you have to reconsider it. Now, what's the bottom line? Simple explanation of medical necessity eventual coverage means that there's existence for therapeutic decision-making. Let me put it to you in the simplest way possible. Will it make a difference? Is if you do a long evaluation and there is no difference, if you see someone on a weekly basis for 10 years and you're not having an impact, either controlling the erosion of a disorder or, for that matter, improving the so-called body part, then what's the purpose? You have not met the criteria for medical necessity. Now, that is the foundation for national coverage policy exclusions. Services that are not reasonable and necessary do not meet the criteria. Now, it doesn't mean you can't argue it, but it also means that you need to understand that these decisions are made on existing literature by individuals who may or may not understand what is it that a psychologist does. A few words regarding documentation. What's the general purpose? Medical necessity. This is essentially to make sure that other people, if you get audited, understand and support what you're doing. It's evaluation and plan for treatment and establishes the continuity of care. And finally, and for many of us, it also allows us to get reimbursed. The basic components, according to the CPT system, which is the official publication of the CPT panel, You have to have a history, examination, decision-making, counseling, coordination of care, the presenting problem, and the time. I want to talk for a moment about time because this is my interpretation of what I've seen in the CPT literature. You have to have date, so forth, so on. Let me explain to you what time is. I believe that time is the actual time, start time and the stop time. Should you consider a technician as part of the report, you may want to consider this. The status, procedure, the results, and most importantly, what's the diagnosis, or I should say diagnoses, the plan for care, and disposition. Now, what's a report? A written report is essentially something that's signed by the interpreting individual. And essentially, it should have some of these documentation principles. What did you do? What did you find? What's your impression? What are you going to do with the patient? And if applicable, time. Of course, the identity of the observer is utmost. Each CT code should generate a separate report, at least a separate section within a report. If separate sections occur, make sure that each section is labeled accordingly that matches at least directly, if not indirectly, the phraseology used in the CPT code book. You may want to have a multi-level system with documentation, including raw data, internal routing slips, and final report. The more levels you have, the greater likelihood that you'll be able to survive an audit if one is pursued. All right, let's discuss for a few moments what time is. It's defined as what the professional does, not what the patient or client does. For intervention, it's face-to-face. For assessment, it could be face-to-face, as in the case of H&B, or professional time, as in the case of the other forms of testing. Again, it's what the professional does, not what the client does. And you see that you have increments in some cases as low as 15 minutes, or in some cases as high as 60, or as we'll see in subsequent, as high as 90. It involves communicating further with others, follow-up, and arranging other services. Non-face-to-face time sometimes is not included in the measurement of bill time, but has been included in calculating the total work process. This is the case for psychotherapy when there's some pre and post time included in the actual reimbursement system. Now, we're going to discuss for a moment how time is interpreted. Face-to-face is what is the standard, and a unit of time occurs when the midpoint has occurred. Do not count time twice. And if a service continues over a period of days, which, for example, could occur in crisis or in testing, as you can see here, is performed on the date that the service was started. Missed time is not bill time. You could possibly bill for the appointment if the contractual relationship is present, however, not if one has not occurred. For time codes in physical medicine and many other testing codes, time has a beginning and end point. And this is some of the non-face-to-face time. Includes communicating with patient, medication management, advocating for services, and so forth, so on. Now, let's define what time is. In 60 minutes, it essentially means 31 minutes. It's 1 unit, and 2 units, it's 91 minutes, and so forth, so on. Location of time really depends on where you're providing the service. However, it could be a doctor's office, it could be an inpatient rehab, and you see the different locations that one can pursue this kind of activity. One has to define very clearly whether it's inpatient or outpatient, because the reimbursement in some cases, it's different. But if you are within a large hospital setting, you ought to define more clearly whether you are inpatient or outpatient. Just because the patient comes in from the outside does not mean that they are outpatient. Physician referral is no longer required in the Medicare system, and most referrals understand this, and of course, most carriers also do not require it. Let me take the last few moments to share with you some things about economics as they reflect the CPT system. We started with cost plus, we went to the prospective payment system, DRGs, CPR, and we're now in the resource value relative value system, RVS system. They're very simple components. Let me share what they are. This was started in 1992, and most codes in the system have all been valued. And Medicare accepts 100% of the RVUs, so does Medicaid, and private payers is now increasing super fast, and I think it's going to become the standard of reimbursement. Now, what is RVU? It basically is physician, work resource value is what the cognitive work, and the practice expense. Those are the big ones. The other ones, as I mentioned, for example, is the geographic. It's not very much. Now, physician work value is essentially 50.9% of the service. Practice expense is 44.8%, and the liabilities I mentioned earlier is relatively small at 4.3%. The balance is geographic. This is a very complex formula, and this is the formula that's used to provide the reimbursement system that we all have to live by. The subcommittee is actually a sister to the CPT panel, and for many years, a longtime colleague and unsung hero in psychology, Jim Georgialakis, has been our representative for that. Again, I want to share with you that the concept of cost is very complex. The direct cost includes supplies, indirect costs includes rent, utilities. We can tell you the average psychotherapy involves 1 Kleenex on average. The number of pencils used in typical test situation has also been empirically validated. This is how seriously complex this gets. The wages go up to 42%, and liability insurance, as you can see, is at the bottom at 3.85%. Let me share with you for a moment what clinical work is. It's mental effort, technical skill, and psychological stress. In essence, the more complicated the work, the more likely that you'll get reimbursed at a higher level. I will say a few words regarding practice expense. We have basically lived on a prayer, so to speak, for many years of what practice expense, but now we have to have it empirically validated, and you can see that we have a very specific system. Now, for those of you who are in the private world that don't deal with Medicare, essentially commercial carriers prefer to set rates or UCR. However, these rates are based on RVUs, which is essentially what you and I talked about. Little by little, RVU is becoming by de facto the way that the reimbursement occurs in all of these cases. So as you can see, the provision of services psychologists provide 40% of outpatient and 70% of inpatient mental health services. Despite this very large, big chunk of all mental health services, the income loss over time has been significant. Over the last dozen years, we've lost 37%. And approximately 1/4 of all psychologists, as reported recently by, I believe it's the APAPO, has resigned from the Medicare program. Now, one thing that's important to say with you is that every 5 years, the Medicare system reviews all our codes. If it's billed over $10 million, there's a particularly large spike. They request that we reconsider it. That's the reason the psychotherapy codes were essentially redone not many years ago. A quick comment regarding, for those of you who don't do basically CPT. CPT is a foundation for Medicare, and if you want to set up a fee schedule, one very viable way to do this is often done by physicians is to multiply the RVU value for selected CPT codes and multiply it by 150%. Now, having said that, carriers basically price. So they determine, in some cases better, in some cases not so good. Alternative payment models, which are now becoming the norm, include quality metrics, outcome metrics, and bundled services, as well as population-based systems. Expect as we go forward that you'll be getting paid not for what you do, but for what happens because of what you do. In essence, we're going to get more and more into situations where coverage with and without conditions is where we're headed. Very complicated system. At this juncture, most Category 3 codes are not being covered unless a specific carrier decides that, or for that matter, a Medicaid system. So we're looking at primarily Category 1 inclusion. Now we're moving slowly but surely from gross charges to RVUs. And at the very recent Medicare CPT meeting, it looks like CPT, an RVU system, will become by de facto the payment of individuals who work in any form of healthcare. You might want to consider some of these ideas, but essentially you should bill for a CPT code once there is documentation for that code. And if you want to look at a particular payment policy that a payer has, consider the McKesson one that I provided in this particular slide. So a billing model might look like this: the procedure completed by the number of units, by the location or site, if applicable, and the date of service. There are numerous problems, but as I mentioned to you, we have increased compliance efforts, maybe not so good, but they have to be attended to, and we're shifting from salary or fee-for-service to productivity. And when compensated by productivity, you're shifting from the actual code to the RVUs. We are going to pursue some additional seminars, and these are the dates. The mental health one, it will be in July, health psychology in August, and the neuropsychology one in September. We'll end up with the future healthcare paradigms on 10/26/15. And for those of you who have viewed this tonight, you're welcome to print out the certificate. That certificate will be online for the next week, and then it will be removed. And this particular presentation will be available through YouTube. So at this point, we will move from my chatting with you folks to actually going ahead and, here we go, to addressing any questions that you might have for us. Okay. So we are having some difficulties. Okay. So it looks like our IT person is telling us that we have some difficulties with Google. They're having some issues. And what we would prefer is that you post your questions on the Hangout page, and I will reply as soon as you post them. So apologies for Google, who happens to be part of my family. My family works there, and sadly enough, they have not come through in this very critical moment. So post your questions, and if not, alternatively, send me an email at puente, Puente, @uncw.edu, and I will answer the questions as best as I can as soon as I receive them. So for now, let me just begin to wrap all this up and share with you that we have provided a little bit of the history of CPT, understanding of how it works, and then what we'll proceed from this particular point forward is discussing the mental health, the health and behavior, and the neuropsych ones. Those are the three pillars of CPT. Again, the foundation for all of healthcare. For better or worse, look forward to sharing with you our emerging ideas in all these fronts. Thank you for spending an hour with us this evening, and I look forward to your questions either through email or by your posting. Have a good evening, and again, thank you. We'll look forward to seeing you next month.